right, well, today I'm going to talk about collaborations with health departments in economic studies for evidence-based harm reduction policies. I have no conflicts to report, and I do not represent any views of health departments or of the government in this work. And I'll first start out to talk a little bit about myself because I am coming in and hopefully will be giving you a couple different perspectives, the public health perspective and the sort of academia perspective as a person who spent the first part of my career working at the California State Health Department and working with syringe service programs during that time. I then transitioned into academia and continued to collaborate with health departments and community-based programs, typically syringe service programs. And so hopefully I can give you both perspectives, that of the health department and that of academia. And I've been working with syringe service programs for almost 20 years now, so hopefully we can get a little bit of their perspectives in here as well. So putting on my public health hat, I do want to talk about some of the considerations to think about when collaborating with public health departments. First off, health departments are really judicious about what additional projects they will take on. And part of that is there's a lot of people who want to collaborate with them. And in my experience, many health departments, at least in the United States, are typically understaffed and underfunded. And so there's only a limited amount of projects that they can take on. It's part of the reason why it's really important to have a synergy of research goals that you can then form collaborations with health departments based on. And those research goals really need to be aligned so that you can help push forth the public health sort of strategy for that time. And finally, I would just say that if you have resources, particular expertise, I think that is really, really useful for forging those public health collaborations. I'm an epidemiologist by training. I ended up getting some economic training along the way, and that has been the reason why I've been able to have collaborations with health departments, is because that expertise is often lacking in health departments in the United States. And so I'm able to offer that expertise to them. And I'll transition now to kind of a little bit of a more holistic and academic sort of, perspective with a couple examples of public health collaborations that I've had and some of the insights that, we might think about in terms of collaboration. So the first is this study that was done, I think, around 2017, 2018, 19, and we had estimated the costs for implementing overdose education and naloxone distribution in New York City. And the objective of this study was really to describe naloxone distribution and the costs of doing naloxone distribution, both in syringe service programs and other types of programs that were delivering the overdose education and naloxone distribution. And so we did microcosting, which you now know about because of Sean. And we did 19 interviews between December 2017 and June 2018 using semi-structured interview guides. We had 19 interviews with 13 of those among all of the syringe service programs in New York City. And then we had 75% participation of other types of programs that were doing overdose education and naloxone distribution. That included 2 hospital systems, 3 community-based organizations, and 1 substance use disorder treatment program that was really focused on people experiencing homelessness. So costs were calculated from the perspective of the program distributing naloxone. Programs were actually receiving naloxone for free, so we didn't include that in our costing of overdose education and naloxone distribution. And the program costs were primarily focused on personnel time. So that was on-site time, off-site time travel that they had to make. And we did startup costs, so the initial costs for starting up the program, and then ongoing implementation costs, so the cost for sustaining that program from month to month. And this is a figure of the sort of things that we were, resources that we were considering for cost. On the left-hand side, you see some of the resources that were provided by the health department for free. So that's like training, naloxone. In the middle, you'll see that there were other types of activities that we included for cost. So they were doing documentation, inventory management, they were doing additional trainings, and they were also preparing the kits by putting them in bags that had educational information and additional resources. On the right-hand side, you could see the different types of training that they would do. You could do overdose education, naloxone distribution, one-on-one in different types of settings, or you could do it in a group setting, you know, perhaps going to an organization, training everyone's staff there, and leaving some naloxone kits, or doing that in for a community-based sort of training. So you could see the costs here per naloxone kit that was dispensed. And so this does not include the initial startup costs, just the ongoing implementation costs. Syringe service programs had the lowest cost per naloxone kit dispensed. And you could see for other types of programs, single-site or multi-site programs, they were more expensive. And the reason why that these other types of programs had higher costs was because there was more medical staff delivering overdose education and naloxone distribution, and they therefore had a higher wage rate for dispensing naloxone. Also, if they were a big organization and they had a lot of medical staff that they had to train, you see the costs go up, which is part of the reason why you see that huge cost for the other single-site programs. And for all of the costs overall, we found that 50% of the costs came from documentation, inventory management, and kit preparation. And so there were a few lessons from the study that comes about from this collaboration. I think from the academic perspective, it was great that we were able to identify the costs of delivering overdose education and naloxone distribution in a way that incorporates all of these additional efforts that's involved in delivering naloxone and overdose education. And I think that was really also important for the health department to recognize that there's all of this additional effort that they might not actually be covering with the funds that they're providing. The other aspect of that from an academic perspective is that many cost-effectiveness studies underestimate these costs. They usually include only the naloxone costs or the costs of delivering that overdose education and naloxone at that moment, and don't take into consideration all of these additional costs that are involved with doing overdose education and naloxone distribution, and so are typically underestimating these costs. And so this was helpful in sort of seeing, you know, what the variety of costs might be. From a harm reduction perspective, the syringe service programs actually really enjoyed being able to share that, you know, they were able to communicate to their funders, which was the health department, that they were doing a lot with their funding, and that additional funding could actually, you know, expand their capacity. And so they were able to indicate to us sort of other things that they were thinking about, such as including fentanyl test kits that would help in that overdose education and naloxone distribution. And we were able to send that message to the health department. And from the health department perspective, I think it was really useful for them because they were able to learn about some of the inefficiencies that they might be able to assist with. And just going back to 50% of the cost was part of documentation, it indicated to them that they needed to do more to reduce documentation challenges, and then to also provide technical assistance with data collection. A lot of the programs had to create new data systems to do the reporting. And so by knowing that, they can actually make some changes to be a better partner to the syringe service programs and other harm reduction programs, and then also really work towards supporting them in a more effective way so that they can do more with that money. So the second example I'm going to talk about is a study that I did in collaboration with the New York City Health Department in 2017 on projecting the impact, both economic and health impact, of implementing overdose prevention centers in New York City. Overdose prevention centers are also known as supervised consumption sites or supervised injection sites in other places. And in the United States, OPCs is kind of the terminology we've taken on. And these are places where people can use pre-obtained drugs under observation so that if they experience an overdose, someone can immediately intervene. And while these programs are really common in many places like Europe and Canada, they have not been common in the United States. And at the time of this study, there had been no sanctioned OPCs in the United States. At this time, New York City Council was really considering opening up OPCs, partially because they were seeing increases in opioid overdose mortality over the years. And they wanted to know, what would be the projected outcomes. They looked at a lot of different things. They did qualitative research, they did community-based research, and for us, they wanted to know what were some of the projected cost outcomes. Would they save money by opening up an OPC? And then also, what are the health benefits? Is it actually going to reduce opioid overdoses in New York City? And at this time, it was 2016, and so at this time there was only 2 studies that had projected the impact of implementing OPCs, and that was in San Francisco and Baltimore. Those studies showed or projected that opening up an OPC would prevent overdoses, HIV, hepatitis C, and link people to substance use disorder treatment programs. And the annual savings were projected to be between 3.5 and 7.8 million. So you might ask yourself, why do we need more evidence? There's a lot of evidence in Europe and Canada about the effectiveness of OPCs. And we had these 2 studies in the US that were projecting also positive benefits. And I think if you think about the timing of this study, policymakers were really wanting to be careful about considering the potential impact of establishing an OPC for the first time in the United States because of the legal status of OPCs being uncertain in the US. And part of that is due to the Crack House statute, which means that it would be a felony to establish an OPC. And so if that was, honored, we would have an OPC closed down potentially after opening it. And so the policymakers were really concerned about that, so they wanted to really understand everything that would occur, health, community, and all the different sort of perspectives. And also just generally, I think policymakers want local evidence that intervention will work in their own location before investing the funds. And so our results, we found, these are all published results, we found that opioid overdoses cost the New York City healthcare system an estimated $41 million per year. And then we had also estimated that if 1 to 4 OPCs were optimally placed, we would estimate around $831,000 and $2.9 million in costs would be saved or averted by the healthcare system. And that if they had established 4 OPCs, between 68 and 131 lives would be saved. And really, the sort of perspectives that come out of this study and this sort of collaborative experience, from the public health perspective, we were able to identify, that actually location really matters in New York City because the opioid overdoses were geographically dispersed. Multiple OPCs would need to be opened in order to have a sizable impact. Other studies at that time were really focused on opening only one OPC in a central location, and this study really kind of showed that you kind of have to think about geography a little bit more, and also kind of supports that, doing a study for the location is really important. From a harm reduction perspective, in 2021, the first 2 OPCs in the United States were opened in New York City, and that was a result of a lot of harm reduction advocacy, research, collaborative research with academics and the public health department, as well as political timing. And then from an academic collaboration perspective, we had been able to sort of understand what some of the public health needs are of the health department and have developed some larger grants as a result of this collaboration. And I think 2 of the sort of lessons from these 2 examples that I talked about is that the value of economic research is really important in these public health collaborations and thinking about harm reduction programs. It may provide economic rationale for stakeholders and or leadership to fund harm reduction programs. I worked in a health department, and there was a lot of evidence for a lot of good programs that never got funded, and sometimes the economic evidence can push it forward just a little bit. And then it also provides some insights on implementation that can help strengthen those relationships between the public health department and the funders, as well as the harm reduction programs. And that's it. Thank you.